I'm Robi from VERVE. Today, I want to introduce you to the Dr. Chauhan here for the difficult intubation for mannequin.
Okay, so as Ruby said, we are going to demonstrate our difficult intubation mannequin. We know there are multiple airway workshop and one master how to navigate through difficult airway. We are basically talking about the anatomical difficult airway. So first I will explain the mannequin, and this is, like Ruby said, is from VERVE. So this is our difficult intubation mannequin. So what we have done, we have fixed the TM joint, and all, I would say most of its movement, the neck, they are restricted. And apart from difficult intubation, we have also given the facility for surgical crying. So both the scale, they are incorporated in a single mannequin. So this is the larynx, and this is the membrane. So when after failed intubation, like you have taken 3 attempts and you are still not able to intubate, immediately, maybe before that, the person who is doing the intubation even after first attempt also you can decide to go for a surgical cry or a EFONA. Okay, then we have given in this mannequin, so when you are able to intubate, it will give you a capnograph. Okay, it will give a ETCO2 number, and then it has got chest rise, which we will demonstrate. And this is the tubing through which if you breathe, then it will give capnograph, and through this also we can create vomiting also. So if you want to manipulate stress, you want to make it more stressful, then apart from difficult intubation, you can throw some vomiters inside the oral cavity, and that we will demonstrate. Okay. So now coming to the procedure. So first I'll take, like, this is a patient, we know that we want to intubate, and we have resuscitated him before we are intubating. So it is understood that we have resuscitated. Now we are ready to take the attempt, the first attempt. So when I say resuscitated means, like, we have given him oxygen with BiPAP or maybe CPAP mask, right, adequately pre-oxygenated and paralyzed. So I'm taking the first attempt. I'll come to this side. So when I do this, so first, whenever I do, so we will have to introduce with the suction catheter. Okay. So now I don't see anything to such up. So now if I show you the inside view, on the side, properly देखो. So I can see, वो दिखाओ epiglottis. एपिग्लोटिस दिखाओ ना, वो इधर दिखाओ, इसमें कैमरे वो रहा, ऐसे कर लो भाई. So I cannot see. Now you go inside. So yes, I can just see the epiglottis. Okay, but I am not able to keep record the glottic opening. So maybe now I want to introduce four blade. Able to see only the epiglottis. With this, only epiglottis, like I can see, but there is no glottic opening. Okay, now idea here is to, now we have devised our VERVE straight blade laryngoscope. It's a rescue video laryngoscope. So I want to use that, and I'll try to intubate this patient with the VL. So this is our VL. I think I have already explained the features. So one must be comfortable when doing intubation. So uvula leads to epiglottis. Okay, so first you introduce the VL, then look inside the oral cavity, then look at the screen. Okay, so I'm not seeing anything here, and then manipulate. Because it's difficult intubation, so we'll have some manipulation. Now I can see the epiglottis. Okay, tube B. So now I have a little bit maneuvering. Now I am seeing the glotic opening also, and so now I am seeing, and I have to, yes, you can see tube. इसको पकड़ो। ज़्यादा नहीं गई बूजी वाला सामान ऐसे कर दे स्टार्ट। छोटे वाले सिरिंज देना।
Don't record, wait, they will be ready first.
This is what we want to show, the capnograph. तो सही हाँ. So now you can see the ETSO2, the number is 39, so we are well inside the trachea, and just to demonstrate further, now we can see from here also. So this is our tube. Okay, so we have successfully intubated with our straight blade laryngoscope. So now, because sometimes you may get some number like 15 or 20, but they will decrease if it is esophageal intubation. But it is like 36, 30, 37, and respiratory rate is 16. So this is what I want to say and want to demonstrate that if you are having difficult intubation, please use this ETSO2 capnograph, so that in a high stressful scenario you are relieved and you can see very well. There is a good capnograph. So we have successfully intubated this patient with our straight blade video laryngoscope. Okay, now the second scenario. Now we will create that vomiting scenario, like that you just go inside casually, but should not ever go. You should go with the suction. So we'll show you. You can now, yes, यहाँ दिखा दो, इधर आ जाओ सामने पीछे, और डालो, फ्लूइड डालो. और डालो. Yes. So lot of vomiters. Now cleaning it. और मत डालो. So this is the second scenario. Okay. So you must always keep it here, left angle. ये पकड़ लो. निकाल दो, इसको निकाल लो. And again, the field is clear. अब करना vomiting डालना. So now you will see vomiters coming. Okay. ये तो पीछे आ जाओ ना यार. Okay. जाना. Give one more time. So from left side. Pressure. Yes. So keep suctioning. So you can increase your. You have taken 3 attempts and it's a failed intubation. So you must have all the time, whenever you are intubating, this surgical cryotherapy set. So now I suppose this is the second scenario that we have failed in our attempt in intubating this patient. So I am going for a surgical try. So immediately this is a 3-finger technique. Come to this side now. 3-finger technique. Feel the space. Give an incision. One more step. Dial it with a finger or a carry. Give me this. Put the bougie. This is the finger. So put the finger, put the bougie. Load the tracheostomy tube. करो करो ambu capnograph. But here we have given inflate the curve. Inflate the curve. So this is the chest rise. But before that, we want you to have that gold standard. Put the. I think we must start the culture of ETCO2 when we are intubating. So, yes, 36, 32. So we are in the right place. So tracheostomy, surgical cryoc we have done, and that is in the right place. So this is the two scenario we practice today. One is like difficult intubation, and definitely this straight braid VERVE VL laryngoscope is going to help you in such circumstances. And secondly, when it is a failed intubation, then in the same mannequin you can do a surgical cryoc. Actually, we take too much time in deciding to do a surgical cryoc, but when you are intubating, then you can have an idea that this patient might need a surgical cryoc, and you should be mentally visualizing. You must take that decision mentally simulating or mentally visualizing how you are going to do the procedure. And with this mannequin, I think these two scenarios are very good. So whenever you are holding a difficult airway workshop, please initiate the delegates with this mannequin so that they have the mindset that if they encounter these kind of scenarios, then they are going to follow those algorithms. Thank you very much.